This week's talk is on research analysis with population level health data at ICES McMaster. And I've got the pleasure of introducing Dr. Aaron Jones and Dr. Hira Mian. I'll start with Dr. Hira Mian. She is an associate professor in the Department of Oncology. Those that work at the Juravinski Hospital are likely familiar with her. She's also the DeFasco Chair in Cancer Therapeutics Research. As a hematologist oncologist, she's leading a research program that aims to optimize patient care for patients with multiple myeloma. We also have Dr. Aaron Jones, and so this is my first chance to meet Dr. Jones. He is an assistant professor in the Department of Health Research Methods, Evidence, and Impact, and holds the Schlegel Research Chair in Clinical Epidemiology and Aging. He's a health services researcher and biostatistician with expertise in the use of health administrative data. He leads a research program on improving health service provision for older adults with ongoing care needs. And he serves as the site director of ICES McMaster. So it's a pleasure to have them both here. I'll be handing over the reins to them both so that you can hear what they have to say about ICES McMaster and research analysis.
All right, thanks. Thanks so much, Tim. I'm just gonna share here, and if you could just well, that is not the right screen. If you'd be able to confirm that you can see it correctly, that would be great.
All good.
Okay. Thanks so much. It's a pleasure to be here this afternoon to talk a bit about research analysis at ICS. And as Tim mentioned, I'm the site director here at ICS McMaster. We'll talk a bit about what that means and what it can mean for you if you're interested in population level health data. No conflicts of interest to declare. And so objectives today are pretty straightforward. We're going to learn about ICS and the data resources that are held at the organization. We're going to see some examples of how ICS data can be leveraged for use in clinical research projects, and then also understand the procedures to access ICS data if you are interested in that. So some background information about ICES. It was founded in 1992, and it is an independent not-for-profit research institute. And it was founded to study the healthcare system in Ontario to promote effective, efficient, and equitable care. And so it is in legislation, in Ontario legislation, as a prescribed entity, which means it is allowed to collect and use personal health information. And it was essentially given unprecedented access to the health records of Ontarians to enable this kind of research and analysis that improve the health system. So currently, there's over 100 data holdings, which are fully linkable in between them and cover health administrative data as well as some clinical and social data. ICS has a collaborative network organizational structure. Again, it was founded in Sunnybrook in 1992. It has spread across the province. ICS McMaster was put together in 2016. And so formally, we are a core research facility of the Faculty of Health Sciences, but we also receive support from McMaster University, from Hamilton Health Sciences, and from St. Joseph Healthcare Hamilton. So some comments about the sort of scope of ICS and the research capacity that is there. I mentioned there's over 100 data holdings, which we'll talk about in detail in just a few slides. There are over 300 ICS scientists. And so ICS scientists they do not work for ICS or at ICES, but they are independent investigators at Ontario universities who access ICS data to conduct their own research. There are also over 300 ICS trainees, so these could be anywhere from undergraduate students up through fellows who are accessing the data to work on their own projects. The research that happens at ICS is quite broad. You can see it's split across 8 different research programs there, a number of clinical areas, as well as epidemiological and population health questions. And so within the last fiscal year, there were over 1,200 ongoing investigator-initiated projects that resulted in 550 peer-reviewed publications that used ICS data. So the reason why you might be interested in ICS is the core data repository, which is really the defining characteristics. And it's a very useful and powerful resource because it is fully linkable, fully de-identified, and for most data sets, we have data on every person in Ontario who has a health card number. So basically, these OHIP numbers get scrambled to form a unique identifier that becomes fully linkable across all the data sets that we have available. So focusing on what data sets these are, we can start with basic demographics. And so another great thing about ICS data is how far we can go back to. Some of the data goes back, as you can see there, to the 1980s. It's not available for every data set that far back, but some of the basic data sets go back for decades. And so we have data on births, deaths, eligibility for public health insurance in Ontario, as well as some additional, or we have 6-digit postal codes, so you can do linkages between lots of neighborhood level factors as well for where people live. And there are some additional demographic identifiers that require special access procedures, but there is data on immigration, refugee, as well as First Nation and Métis identifiers. But the bulk of the data at ICS is the health services data. And broadly speaking, if there's care that's delivered in Ontario that is publicly funded, we probably have a record of it. So we can start with physician claims. We have the OHIP database going back for decades. So this will be fully linkable across patients as well as across physicians, right? So you could track care patients receiving as well as doing practice patterns for physicians. If you think about primary care, for example, we also have records on what kind of group that physicians are practicing in, and the different patients who are rostered to their care as well. So full data on all the OHIP billing claims. We have data on hospital discharges for acute care hospitals, as well as rehab, complex and continuing care hospitals. The data that's available on the hospital discharges is not as detailed, which you might think you could get out of like an electronic medical record, but we'll have data on the dates of admissions, discharges, the diagnoses codes that can be associated with that hospital admission, as well as the interventions and the procedures that went on during that admission. We won't have data on things such as, say, vital signs or other individual clinical measurements that happen during the admission. But we do have data on, again, diagnoses and interventions. We have data on all the emergency department visits in Ontario and other ambulatory care, other outpatient same-day surgery. We have data on all of those events as well. Similar level of data where we have all the dates and times and places, diagnoses, codes, interventions, not so much on sort of very detailed individual clinical measurements. One of the holes in the data set is actually somewhere around the medication. In hospital medication is actually not available in the hospital data, but we do have data for prescriptions that are being filled in the community if you're receiving if the patient is receiving their drugs through the Ontario Drug Benefit. So again, publicly funded drug benefit is the one we'll have data on. We also have data on home care that's delivered, on rehab, on long-term care. We can identify people in long-term care when they're being admitted, when they're being discharged. And we also have an increasingly complete set of the laboratory data from Ontario as well. And so again, all this is fully linkable across patients and again across physicians and across facilities as well. So in addition to that health service data, we also have a number of registries that have been brought in and linked to ICS. So we have the cancer registry, stroke registry, cardiac registry, and there's a number of validated case ascertainment algorithms that get frequently used to identify populations that may be living with chronic diseases. So I personally use the one that identifies people living with dementia quite frequently. Other people use ones around lung disease, around heart disease. So this is another way you can use some of these to try to identify a cohort of interest for your study. And so all of this data so far has all been available on every person in Ontario who has a health card number. But there are additionally external cohorts and surveys who may have been brought in, who you may not have data on everyone in Ontario, but it may be available. There may be a much more detailed level of clinical information available. So Gemini, which some of you may be familiar with, it's a EMR extract of a growing number of hospitals from Ontario. And they might have data, for example, on in-hospital medication use that we actually can't get access to. So Gemini has actually just of this year been brought in and linked to ICS. So that's now available. Again, not on a population level, but on a quite a large sample at this point. We have other cohort studies like the Canadian Longitudinal Study on Aging that have been brought in, which might only be 10,000 people in Ontario, but they have quite a wealth of data that's available there. We have good perinatal data on born and target kids, as well as some of Statistics Canada surveys that are also fully linkable, like the Canadian Community Health Survey. And so then beyond all of this, if you have additional data sets you might be interested in bringing into ICES, your own data that you've collected and you'd like to link to it, that is possible as well. obviously we need to have health card numbers to be able to enable that linkage as well as ethics to make that happen. So that was a very sort of really broad and quick overview of the type of data that is held at ICES. You might wonder what's possible to do with it. I mean, really, I think if you look at the breadth of the studies that go on at ICES, a lot of them are very creative, and you can do almost anything. The sort of cross-sectional time series studies are obviously very valuable, given that we have population level data. So it's quite meaningful to go talk about an entire jurisdiction or talk about changes that might be happening related to policy changes within a jurisdiction. Retrospective cohort studies will be probably the most common study type we see, and a lot of this is really, powered by the fact we have such a long follow-up time. I'm starting to be part of a study soon that's going to be looking to follow up people for 15 or 20 years after a severe pneumonia hospitalization to look for incident dementia. So the ability to go back to the early 2000s to look for some event and then follow people up 20 years is obviously a very powerful tool. There's a lot of people that work on predictive model development and validation with ICS data, as well as health economic analysis. It's good to note that ICS has actually quite well-developed tools to do healthcare costing. I think compared to the other data centers in Canada, we are certainly the most advanced in that. So there's great opportunity to do some economic evaluation using the ICS data. And as well, I want to note the capacity for ICS to support clinical trials, specifically pragmatic trials. And clinical trials has been a priority at ICS for the last 5 years, ICS as an organization is trying to do more to support trialists when they can. Given the nature of the data, it's sort of apparent that ICS is best situated to support pragmatic trials, particularly ones where the interventions are being delivered as part of routine care. You could imagine a cluster randomized pragmatic trial where we can identify within ICS the facilities where the interventions are being delivered. That sort of analysis could be done completely inside ICS itself. It wouldn't even require any kind of data linkage. It would certainly be possible if you have your own external data. You did an individual randomized trial. You wanted to bring that into ICS and link it to pick up outcomes through the administrative data. Again, that's very possible if you have the identifiers for linkage and ethics to do so. Getting your data into ICS is relatively easy, but if you wanted to take the data out, that would be more problematic. And notably, ICS only has data on individuals in Ontario. So if you're doing a multi-jurisdictional study, it's a bit more problematic as well. But I want to note that the Health Data Research Network of Canada, which is it's an organization put together to try to support multi-jurisdictional research within Canada. They actually have a pragmatic trials training program to support investigators as well as senior staff members who are trying to do these kind of pragmatic trials and want to try to do things multi-jurisdictionally. It's a really interesting training program that you can apply to and get some intensive training into that. Just along the trial side, again, ICS is trying to sort of push the edge of what's possible there. There's a couple of things that they're piloting, particularly in some dialysis trials at Western right now, specifically whether or not the administrative data can be used to identify potential participants, can be used to judge eligibility, as well as seeing if ICS can actually do the randomization themselves using some random digits from the numbers. So if you have any interest in the use of administrative data to possibly support your clinical trials, please reach out. ICS is very interested in supporting that. And so before I hand it over to Hira to talk about some of her work using the ICS data, I wanted to highlight one project that we did a few years ago that was published in the New England Journal. I think it's a great example of the use of administrative data. And so this was a population-based interrupted time series analysis that's looking at abortion safety and use around the times where mifepristone was made available and then also made available without any restrictions. And so there's a couple time series plots here. I hope it's not too small to see. But on the left, you can see the proportion of all abortions in Ontario that were medical abortions. You can see that go up dramatically. After mifepristone was made available. At the same time, in the bottom left, you can see the overall rate of abortions actually continued to follow a decline. And then the two panels on the right are the outcomes here, which would be severe adverse events severe adverse events as well as abortion complications. And again, the data is probably a bit small to parse out the lines there, but the key message is there were no differences around the times of when the drug was made available. with severe adverse events or abortion complications. So there were no safety signals or concerns at all around that. And I just think this is a great use of data because, again, because we have the data on the population level, they can put together several different data sets: the hospital data sets, the emergency department data sets, the outpatient same day surgery data sets, to try to pick up all the different outcomes we're looking at around abortion complications, around severe adverse events, and be able to produce some data that was highly relevant. This was published in the New England Journal because the United States was having policy conversations at the same time around these drugs. So I think to highlight a few more opportunities and examples of using ICES data, I'm going to pass it on to Hira now, who will share some of her work.
I think we have you still muted, Hira. So let's see what we can do to unmute you. I know Susie is still here, and we'll see if she can help us with that.
Try just hitting the mic and unmute it at the top. It's not working.
Darn, we are kind of stuck.
Kathy, any suggestions?
You want to type in the chat, Hira, because we're sorry, everybody. We always have a little bit of technical issues with events like this, so we'll hopefully get this rectified momentarily.
No suggestions from me, Susie.
Let's see here. We have another route for doing so. Here, for everyone, here was able to speak before we invited everybody in. So here is rejoining. Let's see if she's able to.
Can you
Hira,
guys?
are you?
Can you guys
Oh, there
hear
you go. Yes.
Yeah, we can hear you.
I'm sorry, I don't know. It was just like totally stuck, and I couldn't even chat. So I was trying to do sign language. All right, let's see if this will work. Windows. Oh my gosh, because
We're still doing well for time, so don't fret.
because you guys probably still. Oh my gosh. It will not let me share it now. That entire screen. I am gonna sort. I apologize. I'm gonna log back in through a different mechanism. It's just not allowing me to share my slides, and I thought maybe this would. So just give me 30 seconds again. I apologize.
I'm going to see if I can give you permission somehow as well, in case it is hidden from me. So I'm just going to make sure.
I think maybe while here's coming, I'm going to speak at the end about accessing ICES data. But if you're sort of wondering what else you might be able to do, or else what kind of studies are done, I think that's a great step to take is to go to the ICES website. Which was that you, Tim, sharing? Or was that Hira? Is she back?
Yeah, I think I'm back.
Oh,
I think I can share.
I'll follow up. I'll finish my thoughts.
I apologize. All right, so hopefully you guys can see this.
Great.
Perfect. Okay, I will not press any more buttons and just start talking. All right. So thank you so much, Aaron, for kind of highlighting all of the capacity of ICS projects. I came on faculty in 2018, and that year, one of the first grants I got was a Juravinski Foundation grant for a multiple myeloma project for ICS. And I have to say that has led to a whole research programs. So I would really encourage a lot of you to really think about this. And so I'll highlight a few of the projects that we've done over the past 5 years. Here are my disclosures. So just briefly, I wanted to just highlight what multiple myeloma is because a lot of what I'm going to be talking to you is around that. Multiple myeloma is a blood cancer. It's 3% of all cancers, but a really expensive cancer to treat. There's about 3,800 new cases diagnosed annually, and the median age of patients is 70 years, with survival really ranging from 5 to 10 years. One of the other things to highlight is that multiple myeloma is a disease of older adults, and really that population of patients who are diagnosed with myeloma in the next decade will increase. So I'm going to just run through a couple of projects that we initially did and just take you through them. So one of the projects that we initially did was we spent a lot of time creating a myeloma cohort in ICES, a cohort that took some time to initially develop, but then once you know that data, it becomes pretty easy. So we used the cancer registry to identify patients with multiple myeloma, and we went all the way to 2007 because at that time a pivotal drug was approved and we wanted a contemporary population. So, we originally had about 8,800 patients. So one of the first projects we did, which was a simple project, was just show that when a new drug in myeloma is approved, it takes a long time for patients over the age of 65, that's on the right-hand side, to start using that drug. And even when that drug is approved, the rates of early mortality, in fact, stay the same for older adults. Whereas if you look on the left-hand side for patients under the age of 65, when a new drug is approved, everybody starts using it, and that leads to actually much less early mortality. So just highlighting some of the difference between how older adults and younger adults are both in terms of drug utilization as well as early mortality. Then one of the other ones I wanted to highlight was, at one point there was a frailty index that was developed for myeloma. It was developed in a clinical trial data set. I saw that kind of come out in a leukemia publication, and I said, you know what, this would be easy for us to validate as the first group globally in our ICES data set to show whether or not it's predictive in real world population data sets as well. So we took this score and we again made some inferences on how to do ECOG status out of ICES. And this was a fantastic validation. We're the only group really that were able to quickly validate and show that there was external validity of this frailty index for outcomes among older patients, not just for overall survival, but also for early mortality as well as healthcare utilization. So that was kind of a neat little project, which was timely and ended up being published again in a pretty great journal as well. Then one of the things that maybe Erin didn't highlight as much, but that we work a lot on is that there is an ability to look at patient-reported outcomes in ICES. There's a separate kind of data holding around that. And this, I would say, is an incredibly unique opportunity that really only exists in the ICES data set. If you look at the SEER data sets, a lot of other population-based data sets, nobody else has this. So, we've been really successful at looking at some of the patient-reported outcomes in a disease like multiple myeloma, where the survival is long, but there's a really high burden in terms of impairment in quality of life. So this was one initial project where we did, where we looked at the number of patients who had a high symptom burden, and so we looked at a number of different symptoms that, these are ESAS symptoms that every patient who comes to our clinic is filling it out every month. So you get this incredible longitudinal data over thousands of patients, and you can imagine how many data points we have. So this was one where we looked at how do older adults do when they undergo treatment. And so the idea here is if you look, from the time from diagnosis is the x-axis, and the proportion of patients with severe symptom burden is on the y-axis. So a lot of symptoms like tiredness, well-being, and pain tend to get better, but we were able to show that things like anxiety and depression actually stay pretty stagnant and don't change as much during the treatment course. Again, just highlighting some other opportunities. One of the other ones that we did was for patients who've received lots of previous lines of treatment. And again, we've spent now quite a bit of time identifying different lines of treatment. In Canada, there was a big push to bring in new treatments for this patient population, but we needed to know what our benchmark was. So we were able to put together this data that, again, other agencies like CADIT that approve drugs can look at it and say, what is the current outcomes of patients that really are quite advanced in terms of their treatment? How long, do they live? And what is the time they get on current treatments? And that helps them benchmark additional future treatments to approve. So this was one little project that we had done. And then similarly, we were able to show that really patients towards the end of life that are received multiple classes of treatment before have pretty high symptom burden. So another area that we can improve. The other one that people kept talking about, which was that among older adults, that perhaps myeloma is not the leading cause of death, that we really need to focus more on supportive care, and perhaps having novel therapies is not as important in older adults versus younger adults. So over here, we divided the group into two cohorts, a transplant eligible and a non-transplant eligible cohort, and just showed that even though the rates of dying from myeloma were decreased, they were still actually quite high in older adults. So here, we really looked at the causes of death in different myeloma cohorts, and also depending on what the time was from the time of diagnosis. So this was, again, a neat little project that is novel data for the world in terms of population level data. All right. So one of the last projects that I'm going to just quickly present to you, and this was an ASH oral abstract last year done by one of our colleagues. And this is just to highlight that, one of the key things we've looked at with the myeloma cohort is how does the randomized control trial data compare to real world setting? So we know that lots of trials in multiple myeloma have really stringent criteria. So when we're counseling patients in clinic about the efficacy as well as this toxicity, it's really hard to generalize that. We know that in myeloma, potentially anywhere between 53 to 80% of real world patients would actually have not been included in some of those stringent registrational clinical trials. And that's due to a number of different factors in terms of just the real world patient selection. So in this analysis, which actually took us a really long time to do, but we basically looked at every single myeloma regimen and looked at what the progression-free survival or the time to next treatment was. And then we compared it to all of the registrational RCTs. So for this particular study, again, we had to go back. You're able to identify chemotherapy regimens in ICES. And so we went and looked at each chemotherapy regimen, the start date, the end date, when the next line of treatment was. And we looked at, a surrogate measure called progression-free survival, really showing that most of the regimens in the real world are not giving the same outcomes as the RCT data. So again, really important when we're counseling patients in our clinic, where we're often using RCT data to counsel them. And then similarly, we were again able to look at the overall survival as well, which again is, an analysis that you can do in ICES. How long are patients living when they start X regimen? And so again, this was quite a bit of work because it is not so easy to identify regimens. So it does take a lot of time to clean up chemotherapy data, but really a very important kind of data set globally. So I think this was the bulk of what I had wanted to just talk to everybody about. My whole point in highlighting is that that initial grant that I put in from the JCC Foundation in 2018 led to one project, which led to additional questions. So it really was kind of an opportunity that just built, and eventually we ended up getting larger grants for ICES projects, and lots of great people have been supportive and involved along this. So I just wanted to, particularly for the myeloma ICES cohort, have a special thanks to Cian, Bran, Anna, and Richard, who are all part of the ICES team. And then we also work with Gregory Pond on a lot of the statistical analysis as well.
Thanks, Hira. That's great. And that's actually great that you highlighted a couple of those data sets that I didn't talk about. And again, there's 121 data holdings or more, and I don't do cancer research. I actually have no idea what's even in the cancer registries, and I think that PROMS data set I haven't used before. So the point being, if you though, I may not know everything about the data sets, but if you are interested and knowing what is in ICES and what might you be able to do. If you reach out to myself or one of the other staff, we can certainly find someone who is familiar with it. There's a whole set of content experts that we have with the ICES data. So I'm gonna share again, and before I get into the bit that I wanted to share around how to access the data, I just again wanted to point out two resources. If you're still wondering what might be possible, if you go to the ICES data site, one of the valuable resources is where they list all the publications, and they have a searchable list of publications here. You can put in your keywords there, or you can actually search by research program by topic here. And that's a great way to get started because you can see what else has been done. And that at least gives you a starting point for thinking some things are possible or some things aren't possible. You can also try to access the data dictionary. Well, you can certainly access it. Understanding the data dictionary is another question because as you'll see as this loads here, it's quite an extensive list of data sources that are available. And in truth, there's actually more that are listed on here. There's a bit of a secret menu that have that you actually have to know about before you can access them as well, because there are sub cohorts that are created. Here's talking about this multiple myeloma cohort that's been created. So there's a lot going on, and again, if you're wondering about what might be possible, we'd encourage you to reach out to us. And so going back to the presentation now, the third, whoops, that's starting from the beginning, which we don't want. The third part of our presentation is going to be on how you might access ICES data. And I'll suggest that, again, you start at the beginning, at the project ideation stage. And if you work with the ICES McMaster team, we can help you with some questions about feasibility. Is this kind of project even possible? What might be able to be done? And we can give you a letter of support to help support your grant application. And notably, to access ICES, to be a PI on an ICES project, you do not have to be an ICES scientist, but you do have to have an ICES scientist who is part of the project team. And if you do not know one or have anyone who might be interested in that, we do now at ICES McMaster have a staff scientist who can fill in that role if you don't otherwise have a scientist that you can include on your project team. So once you've been successful receiving your grant application and we've identified the project team, then you put in, you come back to us and you put in your project initiation paperwork. It's a fairly simple process. It's just 1 to 2 months if it's a simple project to get things initialized on the ICES side. And you concurrently, you're developing your data and your analytic plan. And once all that's put into place, you can kick off the project. And so the way this works for most projects, so it's most projects I'll refer to as these investigator-driven, these investigator-initiated projects. They are ones where our ICES analytics staff will be doing all data management and analysis. So we have 5 analysts who work for us right now. We'd love to grow that staff actually, and they're highly trained in accessing these data sets, which you can imagine for many studies requires a large degree of expertise in how to merge and put these data sets together to make an actual analytic cohort. So for almost all our projects, the ICES McMaster staff will do all the data and analysis. You'll build your analytic plan at the beginning, but then it'll be a recurring and ongoing back and forth process throughout the project where you work with the analyst and they will give you the outputs, which you can then convert into tables, figures, and write your manuscripts. Trainee projects are a little bit different because we typically expect trainees to be doing their own analysis. So in that case, ICES McMaster staff will prepare an analytic data set, so they do all the data management, and then the student that will remotely access that data set in a secure data environment, and then so they can do their own analysis. Things are set up like this because typically ICES scientists don't have the time or often don't have the capacity, the ability to do their own analysis. That's not true for all scientists, and so some scientists can be granted remote access to project data as well. It's not the typical process, but it certainly can be done. There's also a separate access stream that I need to mention, that if you do not want to work with an ICES scientist at all, or if there's private sector researchers who can't go through the normal process, there's a data analytics services, which is a separate access stream. Although there are some more limitations with that in terms of the granularity of data that you are allowed to access. So for the cost of accessing ICES data, again, we have the analytics staff doing the data management and analysis, and they work on a cost recovery basis. The current rate is around $120 an hour. So the average project, I say it costs $30,000, but it depends entirely upon your specific project. Some projects are simple, some projects are complicated, or end up daisy chaining several projects together. So again, this is something that initially we can work with you to try to figure out what a budget would look like. But the sort of median project cost is probably $30,000. A student project costs less because, again, we just have the analysts building the analytic cohort rather than actually doing all the analysis themselves. So a student project is typically about $10,000. Notably, though, again, all costs are actually dependent on the actual time spent on the analysis, not on a fixed cost. There are notably also additional costs for bringing in your own data, and that will depend on the complexity of the data that you are bringing in and how difficult it is to link. And certain other data sets may incur other costs as well, particularly some of the cohorts that may have been brought in and actually have their own data access procedures. So some other thoughts, finishing up here. So ICES, as I mentioned before, is a prescribed entity in Ontario legislation, and that is permitted to access personal health information without consent for purposes of evaluating, planning, or management of the health system. So under Section 45, ICES does not require ethics approval for projects that use just ICES data. So in some instances, ethics may be required. Specifically, if you're bringing in your own data, then you will certainly need ethics in order to link that. I also want to highlight the Applied Health Research Question, which is a funding stream that is funded by the Ministry of Health, specifically for health system knowledge users. So not PIs directly, but knowledge users that are looking to access ICES research evidence to inform planning, service position, or policy development. And so the ARC, to access the ARC stream, the knowledge user puts together a short application. It gets sent to adjudication committee. They decide whether it's going to get funded or not, and if it's approved, then those are fully funded by the Ministry of Health. Again, this is not meant for projects. This is not meant for projects, for research projects that would be fundable through the typical streams, but rather specifically for knowledge users who are looking to access ICES data to make a direct when there's a direct link to what's going to be produced and how they're going to use that to improve their planning or service provision. You can contact us again for more details. We actually have several. We were sort of pushing these over this year. We have 4 or 5 applications in now. And so that's looking promising. And lastly, if you were curious about what it might take to become an ICES scientist, you need to have an Ontario University academic appointment, and then two publications as first or senior author that either uses ICES data or substantively similar data. And again, being an ICES scientist, obviously you don't get any funding for that, and there's no it's not employment. It's merely an affiliation that then allows you to be the ICES scientist who's responsible within that project team. Okay, I wanted to highlight some of the contact information here. Again, I'm the site director at ICES McMaster. Dr. Richard Perez is our staff scientist and lead local methodologist. Brian Steve is our project manager. And there's also a general inquiry line there. And you can email any of us with initial inquiries. Again, we're very happy to help you sort of ideate and think about feasibility, about what projects may be possible. As well as to again, if you're putting in grant applications, we can provide letters of support that can help enhance your application as well. Okay, and that is all I wanted to share today. We're very happy. I'm very happy to take any sort of questions around ICES data. I'm sure Hira's okay as well. Take any thoughts. Again, just here. I have my own research program within ICES that I'm very passionate about, but I'm also very interested in helping connect other researchers to be able to use the data. So I'm more than happy to have a conversation with anyone, even if you're just at the very beginning wondering what might be possible.
Thanks so much, Dr. Jones, Dr. Mian, for this really interesting and informative discussion. The ICES database is, as you just described it, it's a very robust set of data holdings. I got to get used to saying that term instead of databases. There's a lot of public information through our publicly funded health system that goes into this. I guess I'm going to lead into some questions that now are coming in from a few of our colleagues. But I wanted to ask you just about those data holdings, because I wondered, those data holdings, were they when they were put together in the first place? I wonder. I get the sense there's more of an administrative purpose behind those data holdings, as opposed to a research purpose from the onset of how that data was collected. I wonder how that, we can, make use of that, certainly for studying a lot of associations that can happen as opposed to causation, so to speak, and the quantitative nature of the data as opposed to what we do with interpreting it in different lens, like qualitative research. So I just thought I might ask that to kick us off with some questions.
Yeah, sure. So the data, again, the most of the data in ICS is health administrative data. So it's, again, data collected as part of the routine operation of the health system that's not collected specifically for research or often even for clinical purposes. Some of the data, though, and I think probably Hira showed some of that within the cancer data, certainly would have more clinical details to it. So it's hard to talk about ICS data sort of in one overview because there's a lot of heterogeneity. So and this is why you really need to work with people who have some familiarity with it, because it's not always as straightforward. So with the administrative data, for example, you have limitations in terms of what might be measured. Say clinically, that might, again, if you're going to do a study, if you're trying to do a study using just the hospital admission and discharge data, what do you have in there that's good to try to measure the acuity or general complexity of the patient? There's actually not a whole lot in the discharge abstract database itself. We have other ways you can pull this out. There's actually ways we combine multiple databases together to get a good picture of people's chronic disease burden. There's ways we use prior health service use to try to do this. It is still though limited, and sometimes there's a lot of interest, actually, and here I started to mention this too, in doing like target trial analysis or target trial emulation. But that's, depending on your question, that's not always possible because you may be missing key measures. So it is really an instance where you need to figure out what data is actually there, and do you actually have the data to answer your question, because it's not always going to be possible. You may be missing key measures that you need. Yeah.
So it's probably useful to make sure you're involved right from the onset with the project to make sure that the questions are, presented in as clear a fashion to match up with the data set that's present.
Yeah, for sure. And this is, again, why I encourage you to reach out, or if you have colleagues who have used it, to understand, can you actually measure, can you actually get those key measures that you're looking for? Because in some cases, again, I mentioned in hospital medication use is actually not a standard in the if you want to do that, you might have to go through a different avenue, use one of these other cohorts like I mentioned, Gemini, and so we can try to help you figure that out.
Thank you. Now there's a question from Dr. Molnar, one of our nephrologists. Do the estimated costs presented include support to build or create the dataset creation plan? I imagine is what she's referring to.
That is what that stands for. So the costs are given per hour for the analyst. A lot of times we assume the investigator is going to build the DCP themselves. In which case, obviously, you're not being charged for that. So if you want your analyst to do the DCP for you, which mostly they can do that, then they will charge for the time. Often, if you come to us and you're talking to myself or to Richard, who I mentioned earlier, was our staff scientist and lead local methodologist, there's some amount of supports that they'll be able to provide to that DCP and not charge you. So there's certainly some level of support for putting your analytic plan together that say the analyst wouldn't charge for, but in some cases, some people are just they don't want to they don't want to put the analytic plan together themselves. They want the analyst to do it, and then they'll review it. In which case, then the analyst will bill on an hourly basis, just like everything else. But there's an initial level of support that we can provide that's not that we're not charging for.
Next question from Dr. Smita. Do you have data on homelessness and how to track data or anything about our patients who may not have OHIP cards or incomplete information that can enters into that public set of that data holding that you're describing? What then? How do we make any interpretations with this vulnerable population?
Yeah, and I'm going to put something in the chat because I just saw this come out recently. There is a group. Actually, it's not that recent, is it? It's actually a couple of years ago. Maybe I just saw it. But there is a group in ICES that has been trying to put together, it's more of a case ascertainment algorithm to try to identify individuals who are unhoused. And I actually do not know the details of that, but I'll the details of what goes into that identification. But I'll refer you to the paper there to read on it. I think they've published several times to do it. I think what the way these algorithms work, they have to get some gold standard data, right, and then bring it into ICES and then see what they can measure in the ICES data, and then do a validation study. So then they can try to take that definition and apply it provincially. So obviously having people without health card numbers is going to be challenging because that is the basis for the linkage across the system. We do have data in ICS on the community health centers where people who don't have health card numbers may be receiving care. We do have an EMR extract actually from them. That's one of the data sets that does require an additional level of permission to access. But those individuals without health card numbers may not be able to be linked across other sets. But if you just wanted to, example, access the community health center data, which again, people there without health card numbers, that would be possible. And for the data on homelessness or unhoused individuals, again, I'll probably refer to that paper, or you could look to see what else is in the potentially in the publication list about that. But I know there is this group that has been working on that question.
Thank you. That's great. I'm wondering to see if we have any other questions coming our way yet. I don't see any yet. Now, as far as the research opportunities, quality improvement's been such a burgeoning field. What might you say is the within that art of the possible for being able to do some qualitative research with some of this quantitative data set? Have you had much experience, or I'm sure you've got great experience, but what are some of the examples you might suggest for that? A lot of quality improvement scientists that's a growing population in our midst.
Yeah, and it's the ICS data can be useful, particularly. And so imagine, obviously, if you're doing qualitative research, you're collecting your data elsewhere, at least for the qualitative portion of that. But if you're doing quality improvement, if you're doing you're doing mixed methods research, you're pulling it from both sides, and the ICS data is really useful for that. Again, because it's that real world data. You can even if you're interested in a single facility, right? You can go into ICS and say, I'm interested in the hospital admissions for just this facility under these years who had this condition, right? You can identify that, right? You can pull out your specific institution, ask your specific questions, and then take that data, and then that's, again, you're doing a mixed method study, right? And that's the quantitative part of then perhaps what you're doing on your own side, recruiting and perhaps doing qualitative stuff. Actually, the last ICS grant that I wrote was a mixed method study. where I'm using the population level data to talk about some issues around primary care, particularly with home visits and virtual visits, and then on the side recruiting participants in Hamilton. Who have functional impairment, who may have difficulty reaching primary care offices, so that we can do a qualitative bit on that, and then triangulate the findings in the end. There's quite a number of people. I don't know how many in Hamilton, but there's a whole group in Toronto that again sort of are into quality and implementation science and are really interested in these data. There's also, again, I'll plug, if you have some data you've collected locally, again, at your institution, even if it's a small amount, and you want to bring it potentially into ICES to pick up other sorts of measures, perhaps other measures of utilization outside your facility, right? A broader measure. You want to know something or some sort of longer follow-ups that you didn't have access to. You can bring that into ICES and have it linked.
That's really helpful to know. Dr. Mian?
But one little part I was just going to add is that ICS is also extremely collaborative across Ontario. So if you find that somebody's done a project in a different patient population, but using a data set you're interested in, or they've done this, you know, cool type of method that you are really interested in, it's really easy for them to transfer the code over to you. And I found it to be extremely collaborative. So, I've seen projects that were done in Toronto in another type of cancer. And I was like, I really think this is an important myeloma question. Easy to reach out to the group there. They'd be happy to share your code. It's like this one big network. Mac can just use the code that was somewhat generated in Toronto. So that's the other part where I think Aaron's idea of looking through the publications that ICES has published is actually quite helpful as well in giving you ideas of what the possibilities are.
Yeah, it's actually a very collaborative. It's an extremely collaborative network. You can normally email anyone. Like they're very big on reusing code, right? Which is great, because again, you have, say, what Hira did to put together this multiple myeloma core. You don't want to repeat that, right? So it's a highly collaborative network, and sometimes it's tons of work to put together case definitions, to put together case ascertainment algorithms, or even if sometimes people have brought in certain bits of data, project specific data, they can, with permission, share those with someone else as well, right? So it's a great network for working together, especially if you're maybe not as familiar with what might be possible. They're normally a very friendly group of researchers.
And I'm glad you're speaking to that, because that you're describing how you're living the vision and mission of ICES as that collaboration of scientists across disciplines, which I think is really, really important here. And I'm so glad Dr. Mian, that you're here for this, because you can show a nice example of the successes that can be built off of the starting with these data holdings, moving it forward based on important questions, because now you've built a research program, with, to some degree, this is a bit of a launching pad for it, which I think is a shining example of what ICES McMaster can do. So no, thank you. Looking to see if we have any other question for you. There are none at the moment. If there are any questions, please try to get them in. We have a couple of minutes left. Otherwise, I might ask for some closing words from Dr. Jones, Dr. Mian. Anything anything you'd like to, anything, Dr. Jones or Dr. Mian, that you'd like to close this Grand Rounds webinar with?
Not specifically. Maybe to reiterate some of the bits around. We're happy to work with anybody to help you figure out some bits of the feasibility. I personally think the ICS data is great opportunities. I just on the side of sort of writing grants and getting approved for grants, it's great to be able to to write sort of in a grant that say you're using this methodology that's already been used somewhere else and validated there and this and that. And I find that that the people that are reviewing grants typically are somewhat familiar with the ICES data, so it's easy to demonstrate feasibility of accessing the data. If you're leveraging someone else's previous work, you can say how this has already been done. I think sometimes it helps your grant application to be able to identify all these things. So that's a little push. I think most of our researchers are fairly successful, and we can again help support your grant application in any case. So happy to do that.
Thank you. And I think we have a question here on tips for fellows who are interested in getting into ICES work.
And fellows, I assume that means clinical.
Yeah, like our I'm going to broaden it to our early career scientists. I'm gonna go a little beyond just fellows, Vinny. If I hope that's okay for me to take liberty with your question.
Yeah, I mean, I'm happy to answer that one. ICS was one of the first grants I got coming on faculty. As a junior faculty member, early career investigator, everything seems really intimidating. ICS is just a great way to just get your foot in the door. It's a feasible project. It's feasible for it to get funded. The analysts are fantastic. So I mean, it's a huge untapped source. I actually think that I'm not sure why more people don't think about it. Now in oncology, we have all of our groups creating cohorts. We have a lymphoma cohort, a CAR T cohort, and it really is. There's small feasible projects that you can do, and you also have a data set that nobody else potentially has in the world. So I do want to highlight that this is actually a really unique resource. And I think these are great projects for fellows, early career investigators.
Yeah. Yeah, that's great. I mean, so the number limitation is that you do need some amount of funding to be able to do the research, right? And that's often the bet. I think as you mentioned, and I mentioned earlier, I think most ICS projects are quite feasible and fundable. If you can find someone who has extra money as a fellow ECR and they're trying to get rid of it, yeah, we're all happy to take it. Otherwise, yeah, looking for maybe a small grant competition, because you don't need, how much is a lot of money depends a lot on your field, but you can do a great ICS project for 30,000 easily. So, if you have 20,000, can we work with you to get something done? Probably. If you have your own capacity, specifically if you're still a clinical fellow and you have potential capacity to access data, we can even do it for cheaper than that. Yeah, I think looking for little grant opportunities, and we can help you write up a nice, feasible, competitive application.
That's awesome. Well, I really appreciate both of you for being here today, Dr. Jones, Dr. Mian. This has been really informative, and I hope that we're going to start seeing a few more scientists come your way and follow, Dr. Mian, your lead, for example, and see more shining stars coming forward with ICES as a platform. So this is fantastic. So thank you both for this week's Medicine Grand Rounds, and we will call it at this point. Thank you, everyone, for attending.
Thanks.
Thank you. Have a good rest of your day.
Thank you. Have a great day.